Hemostasis and platelet disorders. The last lectures for this course will be over platelet, bleeding, and thrombotic disorders. Qualitative platelet disorders, or thrombocytopathies, are common causes of coagulation abnormalities and are often induced by drugs. If you remember back to when you took hematology, you'll recall that the development of platelets occurs in the bone marrow and begins with the myeloid stem cell, which develops into a megakaryoblast. This matures further into the megakaryocyte, which then sheds portions of its cytoplasm. These portions are platelets, or thrombocytes. The normal range for platelets in peripheral circulation is 150,000 to 450,000 per microliter. A platelet count of less than 100,000 is considered the threshold for thrombocytopenia, which is the most common cause of clinically significant bleeding. Of the total platelets produced in the bone marrow, the spleen stores about 1/3 of the total circulating platelets. The rest are present in peripheral circulation. As a reminder, the average lifespan of platelets is around 8 to 10 days. Mucocutaneous bleeding suggests a platelet disorder. Petechiae are small, pinpoint, round, red to brown, or purple spots on the skin caused by broken capillaries. Petechiae may be present with physical trauma and also with infectious and non-infectious conditions. Purpura or red to purple skin spots that measure between 4 and 10 millimeters in diameter. It is caused by bleeding under the skin due to platelet, vascular, or coagulation disorders. Ecchymosis is defined as skin discolorations larger than 10 millimeters. Ecchymosis is pretty much the same as bruises, although generally bruises are caused by physical trauma, while ecchymosis are due to some pathophysiological condition. Other examples of mucocutaneous hemorrhage, but not indicative of a platelet disorder, include bleeding of the gums, which can be present in periodontal disease, nosebleeds, or epistaxis, which can be brought on due to low humidity or high blood pressure, and hematemesis, which can be due to conditions such as some infectious diseases. Common causes of mucocutaneous bleeding include thrombocytopenia, qualitative platelet disorders, von Willebrand disease, and vascular disorders. Scurvy is a disease resulting from a deficiency of vitamin C or ascorbic acid. A lack of vitamin C can result in decreased collagen production, which can lead to fragile capillaries and subcutaneous bleeding. Telangiectasia is a condition characterized by dilation of the capillaries, which causes them to appear as small red or purple clusters, often having a spidery appearance. We will discuss Kasabach-Merritt syndrome on the next slide. Kasabach-Merritt syndrome is a rare condition seen in babies. It is caused by a vascular tumor, or hemangioendothelioma, that traps platelets and leads to thrombocytopenia. It also leads to bleeding due to consumption of coagulation factors. It tends to appear on the skin or on the surface of an organ. Thrombocytopenia is defined as a platelet count less than 100,000 per microliter. It can be due to a variety of conditions, such as decreased platelet production in the bone marrow, which can be congenital or drug-induced, accelerated platelet destruction, which can be drug-induced or due to an immune disorder, and abnormal platelet distribution that can be due to massive blood loss or hypothermia. Thrombocytosis is defined as a platelet count higher than 450,000 per microliter. Reactive thrombocytosis is a term that refers to an increase in platelets that is secondary to other conditions, mostly inflammation and trauma, as well as surgery. It is usually temporary and does not cause the count to exceed 800,000 per microliter. Essential thrombocythemia is associated with myeloproliferative disorders. The signs and symptoms may vary, but most people with essential thrombocythemia are asymptomatic at first. However, as the condition progresses, signs and symptoms begin to develop and manifest. They may include increased production of megakaryocytes, splenomegaly, and bleeding in several parts of the body and/or thrombotic episodes such as stroke, deep vein thrombosis, and dyspnea. Other symptoms may include weakness, headaches, or a burning, tingling, or prickling sensation in the skin. Some people have episodes of severe pain, redness, and swelling, especially in the hands and feet. Thrombocytopenia is a deficiency of circulating platelets. The threshold is generally considered to be less than 100,000 per microliter. The minimum platelet concentration required to prevent hemorrhaging is 50,000 per microliter. As mentioned previously, thrombocytopenia is the most common cause of clinically significant bleeding, the underlying cause of which can be either congenital, acquired, or due to increased destruction. So, which hemostasis step is impaired? The answer is primary hemostasis, since it consists of the formation of the platelet plug. Congenital thrombocytopenia can occur in patients with May-Hegland anomaly. The cause is unknown. However, large platelets are a common finding, as well as Dolly bodies in neutrophils and monocytes. Bernard-Solier syndrome is a congenital disorder that results in decreased platelets, but the main problem is a qualitative defect. Acquired thrombocytopenia can be seen in patients who have received heparin for longer than 5 days. They may develop antibodies to heparin platelet factor 4, and the immune complex that results from it may bind to platelets and activate them, resulting in thrombocytopenia and circulating microthrombi. For that reason, heparin-induced thrombocytopenia, or HIT, is also known as heparin-induced thrombocytopenia with thrombosis. ITP, or acute immune thrombocytopenia, used to be called idiopathic before it was discovered to be caused by an immune response. It is a disorder that is mostly seen in children and is characterized by a sudden onset of bruises, petechiae, and epistaxis, or nosebleeds. Patients have a corresponding low platelet count, but are otherwise healthy. It occurs 1 to 3 weeks after an infection, such as upper respiratory tract infections, rubella, rubeola or measles, chickenpox, or viral diseases, and it usually resolves within a couple of weeks. It is an immunomediated condition, so the old term idiopathic is no longer used. Antibodies to the virus coat platelets, which are then removed by the spleen. Chronic ITP can affect any age, but is mostly seen in women around 40 years of age. TTP, or thrombotic thrombocytopenia purpura, is an uncommon condition and affects mostly women around 30 to 40 years of age. Much like ITP, it typically develops following a viral infection. However, TTP is also accompanied by neurological problems, diarrhea, anorexia, nausea, and fatigue, and is potentially fatal. It seems to be associated with the accumulation of large von Willebrand factor multimers in plasma. When it is time to release von Willebrand factor in response to hemostatic stimuli, a cleaving protease, ADAMTS13, cleaves the stored large polymer in smaller multimers of different sizes. Thrombotic thrombocytopenic purpura is caused by a deficiency of ADAMTS13, resulting in release of the extra-large polymers instead. Platelet von Willebrand factor microthrombi develop in the vascular system. Circulating RBCs are destroyed, resulting in schistocytes that can be seen on the peripheral blood film. HUS, or hemolytic uremic syndrome, is similar to TTP, but not as severe, and the neurologic symptoms are absent. It occurs mostly in children after infection with certain serotypes of Shigella dysenteriae and, of course, E. coli 0157H7. Hemolytic uremic syndrome often results in renal failure and uremia, which may ultimately require dialysis. Shiga toxins and Shiga-like toxins produced by each of the respective microorganisms get into the bloodstream and attach to the glomerular epithelial cells, which then release abnormal amounts of ultra-large von Willebrand factor multimers. DIC, or disseminated intravascular coagulopathy, will be studied with thrombotic disorders. Reactive thrombocytosis is a term that refers to an increase in platelets that is secondary to other conditions, mostly inflammation, trauma, or some other underlying conditions such as acute blood loss, splenectomy, childbirth, exercise, or iron deficiency anemia. It is usually temporary, and platelet counts rarely exceed 800,000 per microliter, but sometimes can surpass 1 million. Platelet function is not diminished, and morphologically they appear normal. The bone marrow often demonstrates normal to increased numbers of megakaryocytes, but again with normal morphology. Platelet function tests, induced aggregation studies, and bleeding times are all normal. Reactive thrombocytosis is not associated with hemorrhage or abnormal thrombopoietin levels and is generally asymptomatic, other than the platelet count. It tends to disappear when the underlying condition resolves. Reactive thrombocytosis, which is temporary, should be differentiated from myeloproliferative disorders, which are not temporary and would be marked and persistent. Thrombocythemia associated with myeloproliferative disorders is persistent, and platelet counts often reach values of several million with a wide distribution in size. It is 1.5 times more common in women than men and in people over 60 years old. Platelet production is unregulated or autonomous. The myeloproliferative neoplasms associated with thrombocythemia include chronic myelogenous leukemia, polycythemia vera, primary myelofibrosis, and essential thrombocythemia, both primary and secondary. Thrombocytosis makes it difficult to obtain platelet-poor plasma, and overall, increased platelets may lead to falsely decreased clotting times. Coagulation inhibitors, such as antiphospholipid antibody, or APA, normally cause prolonged clotting times because it does not let the APTT partial thromboplastin reagent, which is PF3, react, making the extrinsic pathway slow. However, if there are too many platelets left in the platelet-poor plasma, the fact that there are antiphospholipid antibodies may be masked and not detected. Platelets secrete fibrinogen, factor V, factor VIII, and von Willebrand factor, which can desensitize prothrombin time and partial thromboplastin time assays and interfere with clot-based coagulation tests. Platelets also release platelet factor IV from alpha granules, which binds and neutralizes therapeutic heparin in vitro and falsely shortens the partial thromboplastin time. Thrombocythemia is a condition that results in decreased platelet function. Asthenia means lack of energy. Glanzmann thrombocythemia is a disorder of platelet aggregation. Platelets have an abnormality in the GB2B3A receptor that binds von Willebrand factor, fibrinogen, and fibronectin. This results in poor platelet clot retraction or aggregation. Cases are only symptomatic if homozygous. Glanzmann thrombocythemia is more prevalent among communities where inbreeding occurs. The usual symptoms of primary hemostasis dysfunction are present, such as easy bruising, epistaxis, bleeding of the gums, and increased hemorrhaging following surgeries. Bernard-Soulier or giant platelet syndrome is a rare, inherited, autosomal recessive disorder of platelet adhesion that is usually diagnosed in children. This means, of course, that the homozygous state is required to express the disorder. As with Glanzmann thrombocythemia, the usual symptoms of primary hemostasis dysfunction are present, like easy bruising, epistaxis, bleeding of the gums, and increased hemorrhaging following surgeries. The GP1B, 9, and 5 complex is either missing from the surface of platelets or exhibits abnormal function. Large and giant platelets are a common finding, and platelet counts often range from 40,000 to near normal. However, the platelets typically have a decreased lifespan. Chidiac-Higashi syndrome is a rare, autosomal recessive disorder that is often fatal. It is characterized by abnormal fusion of granules in cells that contain granules. Platelets also exhibit abnormally dense granules, which results in bleeding. Patients have low platelet counts. Primary hemostasis is affected because platelets are unable to secrete their granular contents as they normally should. The peripheral blood shows giant, often round, red, blue, or greenish-gray granules of variable size in the cytoplasm of granulocytes, lymphocytes, and monocytes. Impaired secretion affects all cells, as demonstrated by partial oculocutaneous albinism, which is due to the lack of melanin secretion from melanocytes. Frequent infections are common because white blood cells do not function appropriately. The basic defect is in the microtubules, resulting in fusion of lysosomal granules. All white blood cells contain abnormally giant granules. This image shows a normally segmented neutrophil with giant azurophilic granules. The slide shows a comparison of Chediak-Higashi syndrome neutrophil with a normal neutrophil and a normal basophil. Prostaglandins are a large group of hormone-like substances that are produced throughout the body, but not in a particular organ like endocrine hormones. They were initially discovered in seminal fluid, and that is why they were named prostaglandins, because they were thought to be from the prostate. The two main types of prostaglandins are prostacyclins and thromboxanes. Prostaglandins are produced by vascular endothelial cells, and thromboxanes are produced by platelets. PG12 is a vasodilator, while thromboxane is a vasoconstrictor. Aspirin inhibits both, but at low dosages, around 35 to 40 milligrams, only thromboxane is inhibited. It is the action of suppression of thromboxane A2 by the platelets that prevents thrombosis. Thromboxane A2 is a vasoconstrictor and helps platelets to aggregate. Aspirin stops the production of thromboxane A2 for the duration of the life of the platelet, somewhere around 8 to 10 days. This is why a low dose of aspirin, around 35 to 40 milligrams per day, is recommended for patients at risk of certain cardiovascular diseases. Platelet function needs to be assessed for patients on aspirin therapy or on other platelet inhibitors like clopidogrel, that's a hard one, clopidogrel or Plavix, and in preoperative situations. Platelet aggregometry tests are considered high complexity tests and require very skilled technicians to perform. They are mostly performed in hemostasis specialty labs. An aggregating reagent, such as thrombin, ADP, collagen, epinephrine, ristocetin, or arachidonic acid, is added to a platelet-rich plasma. As the platelets aggregate, the turbidity decreases, resulting in an increased light transmittance.